So yeah, so that's biceps tendon, in the groove, and then this is longitudinal. So have that, and then right where his arrow is the anterior circumflex artery and vein underneath. Thank God it's not pulsing. So then what I'm going to do now is just show you that if you just come out here and you can see that subscapularis here, and then this is actually coracoid right there, and then if I slide up, if I angle up off the coracoid right there, I should be able to at some point find the coracoacromial ligament going across. Right now that's a little tough on him. And then after I've done that, then in my protocol I would go up and I would do the AC joint, and there's AC joint. So we're going to be injecting that AC joint. But first thing we're going to do is slide over and we're going to do the subacromial bursa. So the acromium is right there off to the right, and then there's some spurring, and then there's the supraspinatus coming out from underneath the acromium, and that's the irregularity and tear of his supraspinatus and the obvious impingement that he had when he was alive. So the subdeltoid bursa, if you will point to that, in his case that's not swollen, but it's right here. So you can see that little layer there that has no fluid in it. So that's the virtual space here. So that's the subdeltoid bursa. Do is we use our left hand, obviously. We don't have the patient on their side like I would like them to have them in a protocol. I have my little protocol books. Most of you, I think, already have my little protocol books, and if you don't, just call my secretary and you can get one sent to you for $20 or whatever it is. I don't know what it is. But so they're on their side. You're standing with the machine on the opposite side. You're standing behind the patient. You have the probe in the left hand and you have the needle in the right, and then you approach the subdeltoid from the side. And so I'm going to just act like he's on his side, and then I'm going to actually put bevel up under the probe. Anybody see a needle? Okay, so we see a needle, and then we just put the bevel into the fat pad there, and then we'll see if we actually hit it first time or not. And that's expanding a little bit, so I don't like that. That makes me think that I might be peritendon, because I want to just have it flow. And now, do you see anything flowing? No. Well, guess what? My syringe is emptying, so I know I'm in the bursa. The difference is if I'm in the tendon, then it starts to mound. If I'm in the muscle, and this is going to be, and this guy, see right there, you can see it just open up a little bit. And actually, now that I've got enough volume in him, that bursa is filling up too. But if I come out into the deltoid, see that's deltoid expansion, that's not bursa. And then you see and that's still some sheath. That's not the bursa. The bursa is actually this space right here that's above it. So I turn my bevel and use a jet technique and then push down, and then you can see the bursa is actually right there. There's the bursa. So that's a subdeltoid bursal injection. So now I'm going to just do, this is obviously too long a needle for doing an AC joint, but I'm going to do it anyway. So, all right. So then what we're going to practice after that is AC joint. For all of you that haven't used my paperclip techniques, you can ask my faculty about that. How many of my faculty actually use a paperclip? There you go, all of them. Okay. Okay, so if you don't know what I'm talking about, you better start asking, because all of us that do that are like, and I don't know how much they charge for paper clips, but I charge a lot. No, just joking. Okay. The other thing is this machine's in the wrong place for me. So I set these machines up so that you could be on that side of the patient looking at the machine on this side. You understand? I'm on the wrong side, but I wanted to show you. So bottom line is this AC joint is right there, and then you just go short axis at the 2, and then you see that my tip is actually I'm actually in the joint already. So I hit it first time, and then you just can see it. And I'm actually in the joint. That's the tip down there. So I went short axis. So what we're doing now is I'm just filling the joint up again, and you're like, oh, I hardly saw the needle. Well, that's because that's short axis.
So then I'm going to come down here, and look what I do. I put my head, and I line up my head like this. I put my probe, my bevel is facing towards the patient, and my head is down. I line everything up. I'm not going to inject, but you see the needle coming in? Yeah. So the needle's there, but the whole time my head's down. Still, sometimes you have to do a little gymnastics, especially with the cadaver, that you can, because normally what you do is they'd be up on their side, be like this. Okay? So see how I like hook and place. That thing's solid. Like I've got a good view. It's not going anywhere. My head is down. My bevel's up. Ding. Okay. And then I've already checked it. But you can always, before you inject, just give it a little bump. Make sure the air is out. So you know, it's a little bit different. But
get down, get down, so you can see where the needle's going.
Yeah, don't worry about the screen, because the screen's only going to show what's happening in real life. So if you put that needle underneath that probe and then look up, that's what you need to do.
So when you guys prep this game, are we using sterile?
I use ChloraPrep because betadine times 3 plus 10 minutes. That's per the manufacturer. It's not sterile until it's dry. Right. ChloraPrep is 30 seconds, one wipe, and it's a surgical prep. That's what I prefer. And you want to see your target well. All right. You want to see, like, this is the target. This is the target tissue right here. This is what's going under that. This line here.
Perfect.
There we go. We got a needle.
Your needle's not in line with your probe. That's why you're not going to see it well.
So it's huge. This is a little bit awkward one to start, but it's a big thing. Tell you what we're gonna do, Charles. Listen, no, see how you're still at an angle? You're still at an angle? You need to be like this. There you go, better. Your needle's coming in.
I have a big hospital machine and I don't get an image as good. I have a huge hospital machine and I still don't get an image as good. Machine
See how you had the image? And do a little short axis slide there.
It has a musculoskeletal program, but yeah, they were going to spend this
needle right there.
That one comes with musculoskeletal program.
Advance a little bit more. There you go. There's your tip. Just steepen it up.
Okay, guys, faculty, grab the needles and syringes.
Non-dom hand. And you really have to get your head down to get this one lined up right. And I think you need to short axis slide dorsally.
Well, first of all,
You got to find your target. So, just a couple things. I know you guys have probably been told this. This is what I do. If you're not sure, look over at the probe. I like to have my needle coming from this, and then I drop down. See how the acromion came into view? With a little dorsal slide. And then just come over. This really isn't too messed up. And you can see that hypoechoic line right near where, actually let me move it. Right there where the cursor is, that hypoechoic line extends out. That's a nice target there. So right near that cursor, that layer that rounds out, that's your target.
but are we coming?
There's the needle. The bevel is up. We lost it a little bit. There we go. Looking pretty good. Looks like you might be a little deep to the left. That's a nice picture. Let's see what you got. Give it a little bump. It's kind of a bit of needle feel. It looks like you're in the right neighborhood.
Lost the needle tip. There you go. Keep going, keep going, keep going.
What's that expanding now? Where would it place that in?
You may be in the subdeltoid bursa. It doesn't like give a classic look. Normally it'll run a little bit running under the slide, and then this is running back. So this is deltoid. So you are subdeltoid. But I really don't. I don't think Or at least 2 weeks worth of relief. Is that you lock in, look, and like, here's one that I use all the time. It's when these injections are very straightforward, and actually, most of the time you can just go almost right to it, look up, right to it. Deeper injections, more challenging injections, angles are like this. Now you have much less selectivity from the nuance, much harder is finding that tissue. The trick is there, you line up everything perfectly. Think orthogonal planes. So you want to make sure, okay, there's my needle's coming from here. So you're going to drop it on here, but you don't want to look like this. Either I'm looking like this. I'm sticking. So here I am in axial. Here I am in coronal. When I'm doing like this, I hook my fingers onto the patient. Look, I have control of this probe just with 2 fingers. Drop it down, and I look at it, and then I go, okay, I think I got to go a little bit dorsal. Oh, good. There we are. So before I do this injection, I want to have a good view. Did somebody go deeper?
Now, when we get to anterior labrums, in this case, we actually can see this on this patient, which is kind of cheating because there isn't very many patients you can do this with. But you know, and I'll get the 4C out. But here's the anterior labrum here. So if I come up this way, you'll see the subscap come out from underneath and insert. Here's biceps, and there's subscap. If I just look over here, then you get to the point where you start to look at glenoid. Oh, do they have to kill them here? Okay, so yeah, so can you see the labrum kind of fold back and forth? Okay, so that's our anterior labrum and our glenoid right there, and so that's our capsule. So you know, if you're going to do okay, so don't go anywhere. Yeah, so go right ahead. What's the question?
You're below the coracoid there.
Coracoid is way up there, okay. But right there you can see the anterior labrum. Yeah. So what you can do in this case is the same intra-articular biceps. So there's biceps. Can you see the biceps up there? Can you still see it? Okay. So I'm over the top of the humeral head now. So that's intra-articular right there. That's not in the groove. See, that's intra-articular. And so now
I can't see your probe. Is it long or short axis?
I am
No probe yet.
like this. I'm transverse to biceps. I'm almost sliding to acromion.
Okay.
Now, what I wanted to do is I'll show you that there's biceps over it. Yeah, so interval, you got subscap on that side and supraspinatus on that side with your rotator cuff cables on either side. Your coracoacromial ligament is just to the, see if I can do 3 things at once here. So okay, yeah, so here's your cable. So there's your coracoacromial ligament. Here's your glenohumeral ligament, and this your biceps. Subscap is on this side, and supraspinatus is on that side. And so I'll zoom in a little bit. And now what I'm going to do is I'm going to just say, if I keep going, the acromion should shadow me. So there's going to be the fluid over it, and that's the coracoacromial ligament, and there's the acromion there. So now I'm back over the top of so I can see the biceps. And now what I'm going to do now is I'll start over. I'll show you another thing, which is if I do biceps long, and I get into biceps long, and there's biceps long, I can keep going on biceps, and when I get to this point, I spin the probe and watch the biceps go over the top of the humerus. And everybody sees that that's anisotrophic at this point. Nice subdeltoid bursa. But this is actually where the slap lesions are, right here, where the tubercle of the glenoid is, right there. So it inserts right there. So if you're going to do say a PRP or a Prolo of that, this is one way. For you advanced guys, I also go from between the acromion. But that's biceps there, and then
Your long axis
and I'm long axis.
This is a better image.
Yeah, well,
You can see the anatomy.
and then you can see the needle here, And I'm trying to go lefty here, but and then you can see needle is here.
Pathology in this view, Tom?
Yeah, you see it actually in him. He's got a little slap lesion down there. Now my angle is not good because I'm trying to hold his arm and everything, but I've got that needle. I got that needle, you know, above my target there.
Yep, right.
So I would want to bend down to it. So if I bend down to it, I might be able to get to it. But you know, I'm just going to keep going so you can see that I'm hitting the.
Is the arrow on the glenoid?
Yes. And the labrum is here, and my needle is actually gone over the top. You can see it there because but I would pepper the insertion and do that. So that's your you know, for your slap lesions and your insertion stuff. The other approach I've shown you guys in the past is between the acromion, just behind the AC joint. Here's the AC joint, and then down behind it is that same view over the acromion. It's just not as good a view on this person. Okay, lateral epicondyle. So I'll go over this real quick and then we'll get going. We'll work on something else later, but we've used up our time on this. So where'd that blue cover go? I just want to. Okay, never mind. That's fine. Okay. So does anybody? You see the joint there? And I need less depth, please. Okay, so there's epicondyle right there. And you see the spur on the end of it? And there's joint, but there's a good spur on the end of that. And that just is making me happy. I don't know, what's yellow, 20? Yeah. Okay, well that'll leave some for somebody else then. Okay. Yeah, so now first thing is if you look, one of the things you don't want to do when you're doing this epicondyle thing is actually using a needle and having your hand here. Why do you not want the hand on the other side of your probe? So you don't stab yourself. So you roll your fingers. I usually want that tripod down, but I want the fingers rolled, and then I want the epicondyle in view.
So you're stabilizing the steel in your hand?
Yeah, I'm stabilizing the steel in my hand, and there's the spur right there.
You're going to need somebody to hold that arm still.
And then I'm going to actually get real close to the probe. And there's my needle. And I know I've got to go superficial, so now I've got to turn the bevel so that I can go superficial. And then I can go and I'm just going to see if I got that spur. So yeah, so there's the spur. And then I'm in the spur. And then you would fenestrate or PNT or percutaneous needle tenotomy that. But what I wanted to show you I would usually have somebody holding this hand, but what I'm going to do is I'll use my other hand as a brake. And when I do that, and while I did that, I slid off. So let's go back and sign. So where's my needle tip? So now I know that I've got a spur and a calcification over there. I've got to back out. I'm going to come back. I'm going to turn my bevel so I can see my needle better. I'm going to turn my bevel back so I can see it again. And then I'm going to come in and I'm going to ride right up onto that spur edge right there. Yeah, you hold that. There, just got it. That's percutaneous needle tenotomy, except for that's actually just got a spur. So then now that I'm actually stuck in the bone, see, so what I do now is then you come back and you actually pop back out, roll your bevel again, and then dig into a little deeper spot and get it again, and then you can start to actually go from side to side and really work it and remove it. Okay, so that's what we're gonna today is practice. You saw how I bevel rolled down, so I can see it superficial. Go in there, stick it in there. You're not all you guys are going to go back home and remove epicondyle spurs, but you know it's a good needle technique, and And then what a lot of you will probably do is go home and do this. You can let go now. I think I'm not going to be so. And now if we have this, you can see the. Now what do I automatically do? I automatically don't look over there. I mean, that doesn't even help me at all. I look over here and line up the probe and go, okay, where's the needle? And then once I see the needle, I go, okay, so there's needle. And now you can walk. I'm going to turn the bevel again, and I'm going to walk down and fenestrate the capitular recess and that calcification he's got that's up there. Now I look, and then I turn my bevel again, and then I see I can skive off of that and remove that. But now I'm going to do this. This is exactly. Do you see that calcification that's sitting there, right there? I can't get to that because my needle it won't go superficial enough. So look down, come out, bend the needle. So it's purposely bent now. So now that it's bent, now I can back out and come in and fenestrate it now because I now have a tool. Because before I couldn't do it. Okay, so there's actually ulnar collateral ligament over the top of the joint right there, and then that's epicondyle there. So that's epicondyle. Actually, there's a little spurring on it, so we got a good target there, and then we can actually just come in, bend the knees, come in close, line up on the probe, keep it superficial. And in this case, we don't really have to be superficial because we have so much subacute fat. But because I don't have a needle that's long enough, I can't even get to it. It's kind of scary. I'm not sure I remember. So now what I'm going to do is I'm going to do an epicondyle, medial epicondyle. So the first thing I do is get my thumb out of the way. So once I got my thumb out of the way, I put the needle in, and then there you go. Yeah. So then now you can see the needle tip is right there, and then I'm a little shallow, or I'm a little deep. So I'm going to turn the bevel. What kind of little needle is this thing? You guys got a little tiny thing. So there's epicondyle. So I'm fenestrating the epicondyle right there. And then I can actually walk down into that recess. Now I'm on the ligament. So if I wanted to do a little prolo or a PRP, I could do that ligament right there. And then what I do a lot of times is when I'm done, I'll back out, and then I'll have them go basically right into the joint. So I'm actually just feathered it so the needle is, see the needle? I'm right in the joint. So I can do a joint injection as well. So I'll do all three. Now I want to go transverse so I can see my epicondyle. And once I see my epicondyle, now I want to see where the needle is. So if I see my needles there, and so I'm going to go back longitudinal. I'm going to find my needle, and then there's my needle right there. So once I see my needle tip right there, then I'm going to turn transverse on the epicondyle, and I'm going to move my needle. So I see where my needle is, but see how I've got a broad expansion there? I have to move from right to left to work the whole epicondyle. You don't want to just do one track and then miss the rest, because then you're like, well, that feels a little better. So you want to go from right to left. Okay, so now, so I don't know if you guys can see two bones in there, but there's, yeah. Okay, so that's radius, and that's ulna. All right. And that's the pronator that we were talking about, and there's the canal that's been beat up a little bit. Okay, so when I externally rotate, there's actually supposed to be a biceps tendon inserting there. Sorta maybe. Yeah, there it is. Wow, got to really externally rotate. Okay, all right. So on top of the radius is a triangle that is the biceps coming into view right there. And there's a tubercle. So what I wanted to show you is if that tubercle, okay, guys. So what I want to show you is this: if you find that tubercle, and this is part of my I guess basic diagnostic course. That if you haven't had, it's kind of tough. But the biceps inserts on the tubercle there. But what I want you to see is I slide forward, shush. When I get to the biceps, then what I'm going to do is I'm going to slide the probe up. Okay, so do you see that down below there?
Right. There we go.
See that biceps tendon right there?
Yeah.
Okay, so that's biceps tendon right there. And so I just wanted to show you how it wraps around there. And I'm sure Keith's going, oh yeah, that's Jacobson's move, yeah. So that's, yeah, well, we're calling it the biceps wrap around the radius. And then there's biceps tendon that's streaking across there. And then I'm actually, can you still see the biceps down below? Below there. And then I can see the biceps expand into the muscle. So why I want to show that is because first it pisses me off that he figured that out before I did, but because I'm the one that actually was the one that found that distal insertion there. But now when you slide over here, you can actually see that myotendinous junction of the biceps, and that's just a great way to see that. And if you externally rotate, oops, you can see it right there again. So that's biceps tendon right there. We're going to do a carpal tunnel, and there are several things that you can do with carpal tunnel, and one of them is just use a 25 gauge and go in and dissect the nerve and mobilize it, which helps a lot. You can actually go in and fenestrate some of the cobwebs off of it and release it a little more, or you can use a bigger needle and go in with an 18 or even bigger and actually start to fenestrate and cut the retinaculum. And then in the case of the finished product would be when you actually, let me have your hand here, I don't have a needle, you'll trust me. Okay, you'll hold hands later. But what I do is once we're done or fenestrating and doing that, then I say, now you hold that nice and tight and don't let me do this. And I just keep, and then I say relax, and I bend a little more, and now hold it again, and I relax, and then I've fenestrated enough that the retinaculum will actually pop and open. So you do a retinacular release. I know Dan is back here, and even though the paper that you put together for ACR didn't have really that much of that in there, you are doing that, and so are a lot of my faculty. So we're getting a lot of releases and good results. Okay, so there's median nerve right in the middle of the machine. Let's do a little shallower for me. Can I have a short on one of those? I don't need a spinal. Just any short. Oh well, I measure it to see if it got carpal tunnel. And everybody, I would imagine, knows about the measurements, and measuring it over the pronator quadratus first, and then comparing that to the carpal tunnel, and then if you're documenting it, measure it over the distal radius, the joint, the capitulum, and the lunate, so you can demonstrate and transverse the dumbbell sign, as well as go longitudinal, so you can see that you can document the look of the dumbbell sign. Okay, so let's go up to 2 centimeters, please. So, and then we do our paperclip, and we mark it between the flexor carpi radialis and the median nerve. And actually, this is actually, you can see that in this case, he is almost trifurcated already. Can you see the nerve there? You can actually see that it's trifurcated, and I'm basically over the lunate. If I go to the radius, which is here, I can still see that there's, even a little ulnar branch right there still. And by the way, I just another factoid. When you abduct your little finger and your thumb, what nerve is that? Ulnar. Even the ponus is ulnar innervated. Just thought I'd remind you that the ulnar actually goes around the arch and perforates the adductor muscles, and that is ulnar. That's ulnar. That's ulnar. Just in case you wondered, and that makes us different than the chimpanzee. Their ulnar nerve does not go over to their adductor palmaris, so they cannot do that. They can't grip that way. Their thumb is out like that. So just thought I'd tell you, because most people are like, well, ulnar nerve, but see where my index finger is touching? That's the tunnel of my ulnar nerve in my palm right there, right where my index finger is. So it arches all the way around. So there's actually a release that I can show even my advanced guys in where you release that ulnar nerve there for that opponent's problem. But okay, sorry. So again, I'm going to go under, bevel up, air out, and then I'm just going to go in again right next to the 2 and then see if I can get in there. Now you can see if I do this, I can actually use my blade. See how I can actually rotate my blade up and actually start cutting the retinaculum with my blade. So I can use my blade and I can turn the blade until I'll actually, even if you look, you'll see that you can actually get to the point where you'll use the blade, and once you get hooked into it, you can actually cut it with the blade. Oh, I just felt it go. I don't know if you heard that, but so I just got the retinaculum to go with that procedure. What I'd like to do is also show you Guillon's canal, so that you can see that this is a pisiform here, and there's the ulnar artery that's kind of smushed up there, and the ulnar nerves are the two of the palmar branches. The two palmar branches are right where his arrow is, right there. So we can't really see it very well right there, or the two branches. So we do a Guillon's canal release as well, where we actually come off the pisiform slightly, and then I just blade the retinaculum off the pisiform, and I can feel it. So the same thing, you just that's not holding any volume in there. So that 18, as soon as I put that into Guillon's canal, the 18 just wouldn't let me dissect because I just put too big a hole, so just backing out the hole. But I can feel the retinaculum. So see, I'm used to using the blade to cut that retinaculum enough to release it. And I just felt it pretty much go right there.
Shaving off
the pisiform. And everybody says, well, you're not doing the whole thing. You're just doing enough to loosen it up and use some volume. So that's Guillon's canal. Is if you're going to practice this, you might as well practice finding that joint. And once you find that joint, and that arthritic joint right there, then you want to come in from this angle, because it's actually angled a little bit, and you just come in short axis. And now what do I always remind people? I'm sure Nathan can probably answer this, but whenever we're right before a procedure, I always say, where are the arteries? So we have radial arteries big time, like everywhere over here. And so, yeah, so CMC. So, and we don't want to go through the muscle, the abductor, so you actually can come in short axis, slightly in here, and come in, and this is an 18, and I'm in. As soon as I hit the sub-Q, I was in that joint. And then you can actually see it expand the joint. And then I'm full, so I've got, so MCP is right there. The aquaria veins, of course, we'd have our tendons would be here, and we'd have to learn where our crisscrosses are and all that, but then, then of course you come in long axis this way, and then you get that sheath of the tendon off like that. You can see there's the tendons there, right there. And so then, then that's the A2. And so if A2, and then you'll see that right in here would be the nodules. But I always want to go in proximal or distal to the A2, tape their finger down so that I can actually get in there.
This is what, for trigger points?
Yeah, trigger fingers, yeah. Yeah.
What would be the consequence of knocking off the A1?
Well, I mean, if you get you can get the swans and all the other stuff, but so far what I've seen is the fact that you try as hard as you can to actually dissect that A1 off, and nobody's succeeded. So I think you just are releasing instead. Hopefully I'm not stabbing my probe.
There's nothing horrible that can happen.
Not that's the thing. Now if I turn the bevel, now I can get my needle to jet down on top of that tendon, and then you can see it flow. And then and then you can just keep going, and even going into the tendon, so that you can get we fenestrate the nodules in the palm. And when they have the little puckers in their hands, we literally go where the pucker is. And I'll just show you. You want to hold that a second? I just want to show you that, like he's got a little pucker right there, and if I guided it in, under ultrasound, that you get to the point where you can actually get to the point where you see how I almost can't get through the skin. and then and there, did you feel it? See that flip on the retinaculum right there? And you can actually get to the point where you can actually see the needle underneath the skin, and you can actually sit there and fenestrate that pucker right off of there. I just want to show you. Does everybody see Lister's tubercle? See the lump right there? Okay, so for all you guys, if you go distal to that, the next thing is the scapholunate joint right there. And there's the scapholunate ligament there. And then you can actually assess that. You can do your two-fingered squeeze test to see if it's stable or not. So it's so common. You should know that maneuver. In other words, you put your two fingers and say squeeze. So you see it. You see it. When you make a fist, it doesn't actually get the expansion like it does. You need something in their palm so that they actually can. Because if you do this, it doesn't really make the scaphoid and lunate come apart. No, not like it does when you actually put something in their hand. Kathy's agreeing because you've experienced that or you've heard that before too. Yeah.